So we're here to take a moment to speak about a concept that I haven't necessarily spoken about before directly, but it is implicit in almost all healthcare. Now, the concept that I'd like to put forth for consideration is the concept of who is the actual end user of any form of healthcare. Obviously, I perform osteopathic manual therapy, therefore my consideration is dominantly going to be there. However, if we look at the end user of any healthcare practice, it's actually the patient. So what does that mean? That means that any skill development, any decision making that I'm going through, anything that I'm getting better at, anything that I'm trying to do, my aim is to provide usefulness, utility to the patient or to the client, depending on the terminology that your jurisdiction prefers. What this entails is that all of the things that we do, all of the ways that we aim to build our skill set is really not aimed at us particularly, it's aimed at the patient and the benefit that can come for the patient or that can be provided to the patient through the interface. In saying that, we need to be considering as far as the communication that we utilize, that the patient understands it, that the patient is able to comprehend in a useful way what we're saying, what we're trying to communicate for their benefit. Right? So when they ask, what are you doing? Right? Or why are you doing that? The way that we answer the question is not the way that we should necessarily be thinking about answering it to a colleague. I would say that educationally, what we should be aiming at is actually teaching people to communicate at varying levels. So not necessarily communicating to the highest common denominator or the most technical receiver of that communication, but maybe we should be assessing and addressing whether or not people or learners are able to communicate a concept in multiple different levels. You don't want to be derogatory in this, but almost at different grade levels, right? So could you explain the concept to somebody who was in grade 1? Could you explain the concept to somebody who's in grade 5? I believe I've noticed some videos on YouTube somewhere that essentially have a physicist explaining concepts, deep physics concepts, at varying levels. So at a graduate level, at a grade 12 level, at a grade 9 level, and so on and so forth. There may be some actual value in attempting to educate to that ability, to that skill to communicate the same concept in varying ways or at varying levels of comprehension. Along the same lines, our hands-on skills, our actual technical skills, be it assessment, be it an actual treatment that we will devise after assessment, should be aimed at the outcome for the end user. I have a deep frustration with the manner in which we attempt to communicate technical abilities or technical skills or technique systems, in that they are very much about themselves. They're about showing why they're the way they are, why they're different than something else, why maybe you would suggest a hierarchy. What I would suggest is that there are many things about all these systems that are exactly the same. We are interacting with a patient. That patient needs to be relaxed enough for us to create the goal movement. The goal movement is there to provide increased range, increased capacity for the patient. Anything else above and beyond a change in motion it may be happening, but as osteopathic research stands at the moment, we don't have the capacity to say it firmly. That said, what we should be educating towards, or what might be beneficial to educate towards, is the ability to identify the key concepts in all of these technique systems, aka what's the same, right? So as I say, one of the things that's the same is that we almost always need to keep the patient somewhat passive or very lightly active depending on the situation. But what we're aiming for is to create a goal motion and a goal outcome for the patient. So the end user is the same, and that's kind of the general concept that we're speaking to here. But in the end user being the same, there are some decisions. So we want to talk about clinical decision making. Clinical decision making in the actual hands-on skills can be boiled down to a few things. One of them is your assessment. Now, we've talked about assessment here before, that's why I put these concepts forward. Patient active is a safety thing, so we're considering the end user. So you ideally want to go patient active before patient passive. If the patient can't make a movement themselves, it's not necessarily intelligent for us to make it for them. So if we're smart enough to go patient active, in most cases, in all cases where it's applicable, prior to patient passive testing, we have a major safety component taken care of there. We understand the patient's pain or movements that invoke pain. We understand the patient's apprehension for specific motions. They'll usually communicate that to us. So we're in that concept that I've put forth with respect to assessment, we're identifying the end user again. So the end user is the same, but we're talking about how to actually make these decisions. So we've got our assessment, patient active, followed by patient passive, preferably under as many circumstances as is reasonable. We have the concept that macro identifies micro, right? So a large motion will show smaller problems within it. That's why I say that. So we want to identify a large motion that kind of moves all subcomponent parts in a given region that will then show the breakdown. And it's fairly efficient, it's fairly straightforward, and you already have likely identified where the problem might be if you've done a patient active test first. So again, the end users in mind here, we're looking at safety, we're looking at efficiency, we're looking at gentleness. The idea of having a clear algorithm of your assessment allows you to gather that information as effectively and efficiently as possible to then go on to know where the breakdown in motion is and then what you can do about it, or what you should ideally be able to do about it. The next stage of decision making is, do I go direct or do I go indirect as far as the barrier concept is concerned? So we've spoken about this before. In most cases, under acute circumstances, we're going to be looking at going indirect because we don't want to provoke pain. Acute circumstances, there's likely a high presence of pain. Therefore, we're likely going to go indirect. In chronic situations, it's very likely that we're going to go direct because in that chronic situation, the pain level won't be as high. Going into the direct bind is likely to be better tolerated by the patient. But again, the barrier concept and the choice of which barrier to use really is about that end user, about the patient. So we're looking at this broad concept of who is the end user. It's the patient, and that we're instructing towards being able to appropriately identify the challenges that the patient's having and appropriately apply treatment for that patient. This is essentially technique free, right? It's a very broad thing, it's very bespoke, it's very tailored, but it's tailored based on findings. If you have a scattershot assessment process, you won't find necessarily what you're looking for. You won't find the patient or the problem that that patient has, or you won't find it effectively or efficiently. We've spoken about this before, and the problems with assessment and ways to do it well, so you can go and look at those videos. Once you've found it, then what we know is we have a very patient-centered concept in the barrier concept as to what to do. Ouchie, indirect. No ouchie, go direct, right? As simple as that, as straightforward as that. Once we have performed our treatment to what we think is the best of our ability, and I'm going to say this to you very clearly, it's very unlikely in most circumstances that you will clearly note a change while you're performing a treatment. You very likely won't notice it then. You may notice some things. You may notice change in soft tissue tone. You may sense some ease, but don't count on it. When do you know what your treatment's done? When you reassess the exact same way you found the problem. So you need a clear assessment protocol to start, because that's how you're going to identify the problem. You need to make your choice that is patient-centered as far as treatment is concerned. Ouchie, indirect. No ouchie, direct. And sometimes that's going to be a little muddled, and you will learn that because as you use a general protocol, you'll identify the specifics as you go. Once you've performed the treatment, you will know that you have made a change when you rerun the exact same assessment that you ran before. And again, just circling around this point a little bit, if you don't have a clear assessment protocol, you won't remember what you did to find it, or you're going to have a hard time remembering what you did to find it. So we're looking at the concept of cognitive load here. I'm proposing various systematic approaches to all of this so that it becomes less cognitively demanding to perform very, very tailored treatment. You do need to learn some technique. You need to learn how to control a patient. So that's why I've put forth the control series, and the concept that contact is control and control is safety. One of the ways that I've put forth and made that a little bit more understandable is in the patient positioning series. You can look at that on this channel as well. I'm doing all of this centered at the end user. However, we need to get the practitioner proficient enough to be able to appropriately tend to the end user. So this all keeps kind of coming around to this concept of who the end user is, being the patient. The practitioner has to be able to pay attention to the patient and reduce their cognitive load enough in a treatment and an assessment that they're able to pay attention. So this is all kind of coming together around that concept. And when I talk about my frustration with the way that technical approaches are taught, they are very disjointed. Almost always when you read technical manuals, when you read technical guides, when you read osteopathic textbooks, they will fairly consistently say, when speaking about facilitated positional release, or when speaking about strain counter strain, or when speaking about muscle energy, a diagnosis will be performed prior to treatment. That's really all you get about diagnosis. The other thing that you'll get about diagnosis is a very long list of specific tests. You will not remember all of the specific tests. If you run them all, you won't remember the results of all of them. You will not be able to formulate an appropriate treatment. You're going to have an issue. My general guideline in what I'm trying to present to people is a way to reduce cognitive load so you can pay attention to the end user and create the treatment that's appropriate for the patient. You have to see technical holds, you have to see approaches, you have to learn from example on some level. So although I present a lot of guidelines, I also aim to present a lot of essentially specific things to show you, to coach you through, so that you see the examples of all of these principles or all of these guidelines that I'm attempting to put forward. Don't think principles are infallible. Principles always end up with a boundary. All knowledge has limitations, all guidelines have limitations. So my aim is to, in providing you guidelines, teach you how to run a basic search, be organized, and then when you run into a situation where it doesn't show up, or the problem you think should be there doesn't show up, you know how to create a new process on the fly. Because in creating your first process, you're learning the skill of creating a process, right? So we've spoken about all the subcomponents of this, so please feel free to go back and look at a bunch of the videos. But understand that I'd like to just leave you with this message that we've been circling around here in this video of the end user is the patient. You have to be attentive to the patient. In order to do so, you can't have it's not useful to have a cognitively demanding approach, an approach that makes you think too much. What's next? The next step? What do I have to do? This, that, and the other. You need a very effective, efficient process to drop the cognitive load, and then you are able to pay attention to the patient. You know what to do, you know how you found it, you know how to retest. That's why I'm putting all of this together and attempting to share it with you. So hopefully you find it of use, and hopefully as we go forward, we continue to provide you some utility.